change of venue. It's all about flexible learning approach, keeping us on our toes. Okay. Oh, super, just in case. Okay. Right. Just in case, because this is a ICT conference, I thought we'd have an old-fashioned flip chart. Just in case we want to note down things that we want to follow up on from ourselves. But first of all, have we got pretty much everybody is here. We're just waiting for Tintun who's coming. Yeah. There, that's fair enough. We started late. Okay, let's get it on a minute. Did anyone meet anyone from the Maldives? I've got a feeling they never got here. People from the Maldives. There were 2 people meant to be coming, but I've never seen them. No. They were here? Oh. That's okay. How have we missed them? Yes. All right. Well, that's a shame that we've seemed to have lost them, because I don't think they've been to the other 2 earlier sessions either. Okay. Have time to relax before we get our planes back home. Shall we aim for that and see how we go? We don't have to drag it out unnecessarily. Okay, so today the meeting is finished. So everything we were going to absorb is being processed in our heads. I propose we do 2 things. First of all, any quick feedback from some of this morning's discussions, anything really important things that struck you, and then we go into so what are we taking away from here? When we go home, what are the 3 things say? It's always useful to have not too many things we want to follow up on immediately or a little bit longer term from both the discussions around ICT, but also the larger issue of transformative education, because we've had some broader discussions during this meeting, particularly around the interprofessional education, for example. So if that's okay, should we just kick off reflecting on this morning's? We had 2 very interesting, we had the recommendations, which were specific to Thailand mainly, and then we had 2 rather interesting talks from Gabriel Jung and our gentleman from Japan. Anyone got any things that struck them particularly from either of those 2 presentations around how Gabriel Jung's presentation about how they're using ICT for different stages of the educational cycle, if you like, and some of the wisdom about opportunities and limitations of applying technology from Japan? Floor's open. Any first reflections on what's new that you haven't already heard from the other 2 days? Anyone? Yeah, go ahead. Come and sit closer. Okay.
Session. As far as I know, in Thailand we have a channel to put things on policy. If you think that this is going to be very important and we want to recommend the higher position to make it as a policy, there is a channel. So I think this is a preparation, the preparation stage that they gather the evidence-based information and then they develop the recommendation. The recommendation they present this morning is a recommendation for the government to implement ICT technology for the health educational health professional education. So this is kind of the first stage. After they gather, like when we come for this morning session, they have another meeting, the executive meeting. So all the concerned body from the university are invited to look into detail of the recommendation. And I think after this, they're going to put it in the assembly, something. And then the more stakeholder will be involved. And then if it is approval, that's going to put it forward to the Prime Minister. I think this is the way that they are going to develop the recommendation. And this is in line with the country strategy. Because Thailand, we aim to be the Thailand 4.0 for the next 20 years. So this will relate it to the policy. So I think it is going to be approval, but this is it's a process that they are going to move it forward.
I mean, that's quite an interesting point about how you get ideas from meetings into the formal machinery of government decision making. And Thailand, I think, is quite unusual in having what they call a National Health Assembly, which I'm not sure if any other country in the region has one of those. It meets every year, and it's Anyway, so that's certainly interesting. Okay, any other reflections either on the process of decision making that you heard about, or I mean, what struck me from Gabriel Leung's presentation in particular was that there's quite a lot of free access, open source software and things out there that one could use, or some of the free access to some of the online courses. There are things that one can use and look at without necessarily having to start doing everything oneself. And he gave several quite interesting examples. The one he showed the video on epidemics, because of course Hong Kong U has done it, but nevertheless it looked like they'd got a good band of people talking together, very high class people talking about it, and they'd updated it. So there might be stuff that's useful back home that one can use off the shelf, which is not always the case. Anything else? Some of you are nodding. You haven't got a mic. Just speak up.
We are still starting because up until this year we didn't have any agreement, because last year we had this workshop among our university, and we're trying to increase the bandwidth and trying to buy the I group for our 5 university. But only this year, within the budget year, the Ministry of Health and Sports gave us a green light that they are also interested and planning to implement the e-learning and altogether with the telemedicine in the public health sector. So what we are now trying to propose is that we need a bandwidth, equal bandwidth with all the universities so that we can connect. And we need to buy a software, because software and those access sometimes it is very expensive for us, for our country, because our university are still under the HIH, MOHs. We are not independent, so we don't have the own budget that we can use for these IT implementation. So that is what we are trying to propose, equal bandwidth for all the university, and at first we need to buy a software and access together for this not only 5 university. We have to also include the nursing, dental, and also the University of Community Health, because we have 2 dental university, 2 paramedical, 2 pharmacy, and 1 community. So it's altogether 14 university there, plus traditional medicine. So we need all these for our university, and if it is all together, the cost is going to be very high. So we will letting the minister know that we would like to use that amount of budget for this IT, so that we can go ahead with these the ICT replacing the education reform at the moment.
Replacing the education reform. Okay, I mean, I'm a bit ignorant about this, but usually when you talk about big investments, you also have to talk about maintenance. I don't know if ICT is any different, which is
it is also the same, because maintenance is much more expensive because it is a yearly progressive budget. Buying something on the down payment is something. So they will approve the down payment the first time, but the maintenance budget has to be allotted for each and every annual academic year.
I mean, one thing, I was in the NHS when we first started to get computers in our general practices. I used to be a GP a long time ago. And one thing I remember is the NHS didn't have a single policy for introducing IT into the NHS. And we ended up with lots and lots of different non-interoperable platforms, which was a real headache, and they had to reinvent the wheel. They wasted a lot of money initially. But anyway, okay, what about anything else? I mean, one of the things that struck me, I was quite interested, there's a lot of fancy terminology around, but one of the terms that we were using was flip teaching or flip classrooms, which seems to has become very current. Did everybody understand that use of the term? It became a bit clearer as it went on later, but it was new to me. As far as I can understand, it just means using combined approaches and having a bit of an iterative approach between IT-based and face-to-face. But anyone want to?
Well, the term of flipped classroom originally started when before students coming to classroom to get information, and for flipped classroom, then we're using the ICT to give them the information before the class starts. So when we start the class, and it will be the discussion on how can we agree on something or to clarify one or two things, the muddy things, so that the time of discussion between teachers and students or students and other students will be more effective in the class. So that's the term of the flipped classroom.
Is anyone, apart from Thailand, is anybody working with that? Panarat, you need a mic. Is there one down there? We can have one very fit supporter.
So we use flipped classroom. If you remember in the past when we have class, in the class maybe lecture, and then you assign the homework for the student to do at home. And we found that the lecture is more easier. They can read on their own, but the homework is difficult. Because usually we give the homework that application levels. So that's why they flipped. It's like we give them the material, they read at home. It's right, the material that we use for lecture, they read at home. What we flip the homework from the at home to do in class, with the teacher to be mentor. So it's like the difficult question, we can help them to work on that. That is the way that we do for the flipped classroom.
Thank you. Yes, I have heard this term flipped learning, but to me, as a parent, and I have two kids growing up, and as a parent, I always want my daughters to finish their homework in the school. I think that is what flipped learning is all about, so that the teacher can actually mentor while doing their homework. This is what I understood. But in reality, this never happens, because the teachers are overwhelmed with the number of students in the particular class, and therefore the kids always bring the leftover, whatever homework to be done at the school. But I don't know how this is used vis-a-vis the ICT learning. So that's why I was a little bit confused. My understanding and what they were trying to tell, it was a little bit different. Thank you.
We seem to have several different ideas in this room as well. Yeah, I mean, do you want to say anything about flip? No? No, it's just the term came up, was used so much. I don't want, maybe we don't go down a dead end, but I think the main issue is that it's using different modalities of teaching, and you adapt it in a way that works to suit your problems. But there was also one, I think it was the Japanese speaker, or maybe it was Gabriel Leung actually, who said, he was talking about it's almost an evolution and also style of teaching, and it's a sort of evolution from problem-based learning. He made that point at one stage. Okay, so I mean, going back to the ICT agenda, one thing I thought was quite interesting is, again, a point from Gabriel Leung when he said it's very hard to get good IT professionals into universities, and it's also true into ministries of health and WHO, frankly, because they don't want to come and work. So looking for young, bright graduates who can then work under supervision seemed to be a very pragmatic approach. And I'm pretty sure every country in this room has got some young, bright IT graduates around. It's just finding them, but making sure they work within good guidance from the person in charge of education, so they can make sure it fits with what you're trying to do and just doesn't become too high tech. Okay, yeah.
I speak loud enough. I agree with what Philida says. Like in my institute, we invest quite a lot of money to develop the IT system. So we plan to be an e-office, no paperwork. Everything has done into the internet, so no paperwork. But still, it is in transition, so we do both things, paper and e-office things. So it increased the workload. And we invest quite a lot of money to hire a programmer to develop the program. But since we contract out, when the program collapsed, the office almost collapsed as well. So we have to have our own IT. But still, it is the problem because hire the IT person is not easy. You need to hire them higher enough to retain them in the office. But as a civil service government, you cannot hire them like the public sector, the private sector. So the turnover rate is very high. So once you do plan to invest in the IT system, please take into account the maintenance system. So it will become like what we are facing right now.
Okay, I mean, again, we've discussed two things this week using ICT. One is for learning and one is for simplifying bureaucracy. Hands up around the room, in whose job are we still at the stage, like you were just describing, where it's not simplifying bureaucracy? At the moment, there's a transition where it actually seems to often add to the workload, but it's a gradual thing. I mean, in WHO, we've had 10 years now of an online management system. I would say half the things have got simpler, and the other half we're still doing both paper and electronic, and there's a big push to go electronic. Any of you who've ever been to our meetings, we're now trying to be much more electronic and less paper-based. You can see I'm very electronic. But it takes time. I think that's the message. It doesn't simplify immediately quite often. It takes time. But has anybody got some positive experience on the bureaucratic side? Because that's been one dimension of this meeting's discussion. Is it on your day-to-day job, going more using ICT? Has it simplified in Sri Lanka? Has it simplified things yet? And if so, in what?
We are not very much using ICT for day-to-day management.
Yeah.
But again, when we are using that, again we are facing the same problem of maintenance. And one of the messages that mentioned here is that it is good to have personnel within the system rather than outsourcing. That was the key message that I think about 2 or 3 speakers mentioned that it is better to have people from inside, and their capacity building is necessary to maintain the ICT system rather than getting people from outside to maintain your system. So that's one of the key messages I got from here, that rather than allow me keeping the people outsourcing, to increase the capacity of already people who are inside in relation to ICT maintenance. That's what one of the messages that I got from here. Most of the presenters told that outsourcing was costly and outsourcing doesn't have a standard process, and that was the key thing. Really? About 3 or 4 speakers mentioned.
Really?
Yeah.
Okay. It's interesting because it's very fashionable to outsource these sorts of things. So it's interesting to hear them say that. Okay. All right. So, any other reflections on specifically this morning's sessions? The parallel sessions. You've touched. Yes. Go ahead.
Professor Gabriel mentioned that about the question banks.
Oh yes.
Yes.
Yes, that was interesting. The question banks. I was going to ask if anybody can get questions out of the question banks, or whether you have to be part of the inner circle. Does anybody know? Because
one idea I got from that is that we are conducting our public health workforce training in about 8 training centers. So one of the issues that came up always is that we are centrally made questions and not taking the inputs from regional training centers to the center when we are formulating the questions. So that is one way we can adapt our system, that where we can have question banks from all the regional training centers and ultimately deciding what to be put to the exam.
So do you have one standard exam for the country?
Yes,
or do you
one standard curriculum, one standard training program for public. We have mainly public health midwives and public health inspectors, 2 categories of public health workforce. They are training at 8 regional centers and one central location. So what the regional training centers are complaining is that their inputs and their concerns are not reflecting the questions.
Oh, okay.
So that if you can have question banks and asking them to send questions into this bank, and then ultimately board will decide what to be put at the final exam. I think that's a good way.
I was also wondering about between countries, because what was interesting to me is that there were 20, 30, maybe more institutions involved in this network globally, and there's only so many ways usually you can think yourself of how to examine a nurse or a midwife in their final examination, or a doctor. So maybe I'll follow up with Gabriel and find out if this is something that could be a resource if people are interested more broadly. I suspect you might have to both contribute questions as well as take questions, and it sounds like they had quite a systematic approach to the standards, to judging the standards and utility of the questions. But it was an interesting idea. I hadn't heard about it before.
I was a user of the Ideal Hong Kong item bank. So when I was a university lecturer, I was the one in charge on developing the items, the questions. And having the Ideal, being a member of the Ideal, so you need to pay for a certain amount of money to be in the network and to contribute, I think, around 200 to 400 questions per year from your institution. Well, the trick question is the question from other country applied to your local setting? That's the biggest issue that I needed to overcome when I was work there. The idea is to get the question, the idea of the question, and make it into your own question. That's the best thing you can do with Ideal, not just pulling the question and put it on your exams. think that's one thing that you need to consider before you want to join the ideal network. But I think being a member of the ideal network, the item bank network, is very helpful for you as institutions or as a, well, maybe as a country. But I think it's more towards the institution rather than national level.
Yeah.
Thank you.
If I understand it correctly, sorry. I think the question that will be put in the bank is a standard question. So it's not just ordinary question. You just develop it and put it in the bank. So it have to pass some test, like a standardization test, and it should be the one that can differentiate the knowledgeable students, whether they are knowledge enough or not, something like that. So it has to pass some things, some standardization things, and then it will put into the bank, right?
I think they have a classification of items. So you can make it a recall question or a reasoning question. So there will be a code. If you pull a question, there will be a body of questions. There will be, well, if you choose multiple choice, there will be options. If you choose essay, then there's a leading question. But the interesting part of the item bank is they provide the matrix of the difficulties, the reasoning levels, and everything you need to know and you want to put in your blueprint, your assessment blueprint, something like that. So, well, from institutional point of view, you need to provide your best question to be put there rather than putting anything you write and just submit. So maybe your point is right. Thank you.
Okay. One other thing we've heard quite a lot about, particularly today, I think, is how you introduce changes and one of the things that struck me about this was particularly in terms of changing approaches to teaching and the learning of students. And one of the points that, again, Gabriel Lung made was, first of all, look at your admissions policy, how you select students in the first place before they come into the course. And you're looking and not necessarily going for the top grade students, but going for clever enough students who can be competent, but not necessarily going for people with the best marks. Now it's interesting to hear that, because I think the cycle, again, I'm not an educationalist, but the cycle of approaches to admissions policies has changed a lot over the years in the countries that I know, and it's gone more and more towards exam results and further away from interview. But I was wondering, in experience around this room, what about, have there been changes in your selection policies to try and ensure you're recruiting health workers who will be the type of health workers you want 20, 30 years' time? Do you know what I mean? And you select for qualities that are more than just cleverness. I think that was the basic message. But have any of your selection policies changed? Yes, Mema.
Because we have already planned, and actually we are trying to change it last year, but there are a lot of discussion between the Ministry of Education and Ministry of Health and Sports, and because we are going to select the students which have passed the 10th grade, the matriculation from the Ministry of Education. So actually we are ready from our medical university's point of view. So we are planning to introduce that with the aptitude tests and also a selection test by the end of 2018 or early 19.
And why did you decide to do that? What drove you to that?
Well, because there are a lot of students. When previously we are selecting the top best for which have finished their matriculation, and we are start experiencing some of the students after the first or second year, they are not quite interested in becoming a doctor anymore. Yeah. So they wanted to change their profession, and it's quite difficult because if they change in the first year, or first year, it is okay because we don't have that first 2 foundation year like the other country, like finishing BS first and then going to the medical year. So we just go through 7 years in our university. So that is why we are trying to select. They have to be competent with the marks, matriculation marks first, plus the aptitude that they really wanted to become a doctor. So we believe that in that way we will be more have a retention in our workforce, and also with the rural retention also, because those who wanted to really become a doctor can come to the university.
I'm going to slightly digress because this is a really important issue and we haven't discussed it extensively, but because it was mentioned today I raised it. But let me digress. In Thailand, one of the things that Thailand has done is put a big emphasis on recruiting, selecting students at different levels from local areas, but particularly for nurses where you have regional training schools. On the evidence, it's not just anymore the assumption, but on the evidence that if you select into people from there locally, train them reasonably locally, they're more likely to stay locally without any forced policy of compulsory, which is, I think every country's tried compulsory retention. Now, has any other country begun to think about doing that, trying to select more from students from local areas? And the other thing Thailand did, I think, for doctors, was the rural doctors where you didn't select the best students necessarily, but if they looked like they were going to be good enough, you brought them in and they had the same exam at the end, so they had to catch up very quickly during their training, but you allowed them lower entry standards in terms of exam results on the basis of other assessments. That's quite a brave policy, you might think, but it's worked, as I understand it. It's been very effective at getting doctors. Probably if you look at WHO guidelines on retention, that's probably those are the 2 most effective policies beyond the financial. I know there are many other things you can do, we all know. But has anybody else tried different selection criteria for people coming from less, more deprived backgrounds? Has that come into the policy?
We do have that already. We have already selected past 6 years, starting from past 6 years now, those students from the special outreach area. They have the special category of selection, and also with the lower marks, but they have to sign a contract that they are going to go back to those outreach area and serve for 3 years. So they are now reaching the 5th grade now, and after another years they will be finishing. The first batch is going to become out. So we are hoping to see whether they will be going, because in our country the problem is that after you finish from the university, if you to become a doctor, you become a civil servant. All the doctors are civil servant. We don't go like a NHS, like a contract doctors. So after finishing your contract, you have to apply for another job. In our country, we become a civil servant. So they have, as a civil servant, rights. After about 3 years, our law is that they will be able to attempt for the further postgraduate training. So if they are going to attempt for the postgraduate training, and if they pass their selection, they will be coming out of that area. So we were thinking about the limitation, the time frame that they have to serve there, and coming back to the central teaching pool where they can further continue their postgraduate training. So this is what we are thinking.
So watch this space. Watch this space in Myanmar. 1 more year, and you're saying that group is going to graduate next year. Very interesting. What about Indonesia? Is there anything similar?
Well, in Indonesia, actually, we're moving away from the standardized multiple choice admission test. So there are national regulation in place that each institution need to have additional qualitative tests to assess the students. But one thing then we're not agree on yet is what kind of test. most institution defines it as a psychology test. But in I'm an educationist, so in the health profession educations, there are movement towards using the MMI, multiple mini interview, just like Gabriel Leong said, when it started in Canada, McMaster, and in UK they are started to use the I for SGT. I forgot what's the abbreviations. Situational judgment test. Sorry. So the tests are. They said that the ones who score on a certain range of score in that test have a better outcomes when they become a doctor. But it's still a question, and we still need hard evidence on whether these people will become a better doctor compared to the standard multiple choice questions. And the other thing is about the outreach selection. In Indonesia, there's a regulation, and it's in the it's in the accreditation form. So you need to receive students from mostly from eastern part of Indonesia.
Okay. Yeah.
Because the less developed part of Indonesia, so you need to, well, maybe 5, 10, or maybe more, depends on the accreditations, so that they will be more, there are more chance for them to go back to their place.
So it's a positive discrimination.
Something like that, yes.
But a bit like they did in Africa, South Africa, I think they had percentage with the Black Empowerment Initiative, or whatever it was called, BBI. Okay. In Bangladesh, anything happening in terms of selection? Because this is, to me, this is part of transformative education. It's how you rethink, how you...
Thank you. First of all, I would like to give my thanks to the organizer who organized such a nice conference, and the 4th Annual National Health Professional Education Reform. And I would like to thanks my to WHO, who, without their support, we could not attend the program. So in my country, the main things, the selection criteria is based on their grading system. After grading, they have they went to give an exam, MCQ, and who got the maximum marks, they are provided in medical education. And after that, in some situation, when second year and third year, some students did not like. They say, my parents are indulge me to exam in MBBS. So some of them may quit from. So this time we have a discussion that we need to some viva, whether they came with their own interest or by parents. No, this is the main, very difficult situation in second and third year. And after that passing, we have the service system who like to join in public university. They need the BCS examination, and some went to the private college. So when they entered the government medical college, they prefer to side in town, in city, not willing to go to the rural area. But when our DG and minister select them to work in rural area, sometimes they quit the job. And lots of private medical college, so some of them enter into that. So lots of good students, good doctors we lost sometimes. So we think this is our really problem.
So maybe you've got some ideas from the discussions here about how to tackle it. It's interesting to hear 2 or 3 countries already trying to. It's a chronic problem. Okay, so I'm conscious of time and people's interests in using time in alternative ways. I won't mention the S word. Just coming back, why don't we spend, we've got about 45 minutes, let's think let's go round table and see what your big takeaway ideas are. 2 or 3 things you'd like, things that you've found very interesting, and things you want to do when you go back. And then we can do a second round, which is what might we do together, as opposed to the first round, which will be individually. What do we want to do? So, where shall we begin? Should we begin with the bottom right-hand corner? Are we going to do it? How are we going to do it? You've got 4 people from Myanmar. Do you want to have different? You come from different jobs though, so you might have different takeaways. 1 person from one country. Have you had enough time to think? Okay, you can always 1 person from one country, and people can chip in if there's additional ideas. Okay.
Well, at the end of the wrap up, I think which we clearly we got a clear message that ICT is important for the medical education, so that we need to.
Is it okay if we write up on the flip charts some of the big messages? Okay. Could someone help with being a scribe? No, Panarat? Okay, sorry to interrupt you. So, Myanmar, first big takeaways. Sorry, I interrupted you completely.
Well, change to ICT is necessary. We have to do it, but there's also message that we learn is that it is complicated and expensive. But we think we will have some help and ideas from our fellow country and also from WHO that going to support some of the aspect for our medical education university in our country. And another thing is, even though we need to change that ICT, it's going to take time. We are not going to be changed within even within a decade or so. To meet the standard of Hong Kong, Singapore, and even Thailand, I think we need to take a lot of time. So we have to do that. So the main drawbacks in our country is still that our university are still under the one umbrella. We don't have the independent budget for developing the ICT. So like the Thailand, we have to put it up to the ministry and then also up to the government for the allotment for the change of ICT. And we also have knowledge that there are a lot of the access and the modem that we need for these establishing the ICT one. So, and apart from that, with this interpersonal education and interprofessional education and interprofessional teamwork base, which is also important, and I think we have to develop that also. In the other university, especially in Thailand, you are under the same faculty university. There are a lot of different faculties. In our country, it is a different university. So we have already had one workshop how we can bring in those combined interprofessional education and interprofessional workshop. And because yesterday the 2 research project which coming out, which is measuring how to improve. I don't believe that it is totally thinking and targeting the improvement. It is targeting improving the teamwork, so that the care of the level of the medical care is going to become up. And with this teamwork base, I think we can further reduce the mishap and also the legal complaints in the hospital and all the medical centers, even up to the rural areas. That is the message that we grab from this workshop.
Okay. And to what we'll come back. Yes, that's the messages. We'll come back to the action. And have you got some specific follow-up points in the next 2 to 3 months that you were thinking of? You're going to follow up on the budget for IT. That's one thing I hear.
Can I add some point? Personally, if
your team agrees.
Okay, because I don't have time to discuss with others. So what I've learned from this forum is really interesting and very informative and knowledgeable. And what I learned from, especially from the evening session, is district health system and district health management and learning. So what I would like to do when I go back to my country is I would like to introduce some pilot, maybe a kind of pilot testing regarding to the community engaged health professional education in our country, maybe in some midwifery and nursing and midwifery school, because those schools are situated in the rural and some of the districts and townships. So I can propose a pilot project regarding to this community engagements, and because they need to get some experience before they go to the real world. So for me, I don't have any engagement with the community, and after I graduated, that is my first time to deal with the community and to deal with the patient. So I don't have any experience. Actually, I have got 2 weeks field trip to one of the township, but I think that's not enough. We need to experience and we need to understand their condition, and we need to be sympathize, and we need to understand well what their conditions, and we need to put our feet in their shoes, so something like that. So for the students, medical students and nursing students, they need to get some experience, some exposure to the community, and they need to engage, something like that. So I would like to propose or make a proposal to do some pilot project regarding to the community engagement learning in some of the nursing school or something like that.
Okay. In a way, doesn't that link quite nicely to the thinking going on where the rector was talking about earlier of in the fifth and you're focusing on nurses and midwives, you're thinking of medical students, but the notion of getting some interprofessional education going in the 5th and 6th years, say, which would involve, I presume, proper groundwork, because that's the way you get into. You can't do interprofessional education in a classroom. Very simply, I don't think. Tintin, are you going to have a word on that?
Dr. Felicia, I think for all three issues, ICT, interprofessional education, and community-based medical education, community-based health professional education, we have started since some period, but I don't want to say we need to change. We need to strengthen and we need to develop in some areas. But for the IPE, we just start. That's why we need to change our teaching learning strategies to integrate interprofessional education. But for the ICT and also community-based health professional education, we need to strengthen and develop. We need to develop our infrastructure. We are also asking budget for the infrastructure for our medical and allied health universities, because in our universities, almost all lecture rooms are equipped with computer, multimedia projector, PA system, and also we use ICT in teaching, learning, method and strategies. We use digitalized histological styles in teaching and also in the assessment. Also, we use a live demonstration of surgical operation from OT show in medical university lecture room, etc. And also in the library, we use computer with internet access, free Wi-Fi access, ebook reading, learning videos we also produce, and then interactive medical CDs and DVDs. So some area we need to develop. And now also we plan to use the Aneta March, because I saw one Aneta March on the second floor the day before yesterday, And we also plan to use this kind of, teaching learning, high technique teaching learning aids in our training institution, medical university. Our minister also allowed to buy these anatomage. So, but we also need to, invest many things especially at the infrastructure facilities in all universities, and also in the area of teaching learning aids and teaching learning media. This is one point. Another thing is for the ICT and administration, we also need to develop. We are also developing HRH database and HRIS database, and I think we will be finished at the end of this year. And also we are also piloting the student registration, in University of Medicine, Mandalay and University of Medicine too. And we also need to develop web development to promote interaction between students and mentors, something like that we also need to strengthen. So for the certain extent, we have introduced already ICT. Also, we use the software, OMR software, optic marking system or something like this, OMR software for the assessment of clinical subjects and also in the postgraduate selection examination. And also we use some database. We also received the Henry and Harris database from the WHO. So our postgraduate students can access these websites, and also they can apply in their thesis and research activities also. So in many areas we have introduced, but some we need to strengthen, and some we still, we can still continue. Some area we also need to start. For example, like my colleague from the Indonesia mentioned, for the question bank, we also need to develop this kind of question bank. When I visited to the Adelaide University 3 years ago, I found that they have a very strong teaching learning units in the University of Adelaide, and they have this kind of question bank. But the issue before we put the questions in, especially MCQ in the question bank is we have to calculate the difficulty index and also discrimination index, whether these questions are valid or reliable, or as my colleague mentioned, in which level they are going to assess, from the just recall of facts to up to the interpretation of data and problem solving, critical thinking and synthesis level. So another thing is the one who take responsibility for this question bank. It's a very, for my point of view from as a medical educationist, it's very, very dangerous if we appoint, not appropriate person to take this responsibility. So before developing the question bank, we need to establish a strong teaching, learning, or medical education unit, whatever we call strong health professional education unit in the respective training institutions. This is my point. Thank you so much.
Okay, thank you very much indeed. Let's move on to the take-home messages and action points from Indonesia. Who's going to?
From Indonesia,
he's going to do the 1 in 3.
Okay, I'll do the 1 in 3. So in Indonesia, actually, we are developing the academic health system in each provinces. So we are planning to have 1 in each provinces, but we're piloting with 5 academic health system, mostly in Java. Why I bring this up? Because this is the larger picture. IPE will be a part of developing the academic health system. The academic health system is the platform for teaching, research, and health services based on university hospitals. And actually, we will follow it up tomorrow. Because tomorrow evening there will be a 2-minister meeting, and we have to prepare the Minister of Health and Minister of Higher Education. This is the big picture. Developing the IPE will be led by an IPE consortium in Indonesia. Well, the IPE consortium, I think will be similar with the Thailand currently have the National Health Professional Education Reform. So we're planning to develop something like that. And the task of the IPE consortium is to develop an IPE center in Indonesia, because we already have a sporadic growth of IPE, but no one coordinating it and no one knows what the other do. And one thing that, well, maybe I'll talk about this later about the how can we work together. And about the ICT implementation is how to support the academic health system and also the IPE, teaching and learning activities. Because there are two things that we are emphasizing in ICT implementation in Indonesia. The first one is we want to create a big data for education. But the big data for education will have two components. The first one is for the administrative things, and this is we already have in form of pangkalan data. It's like a data center for higher education. We already have this, but the one that we do not have is the ICT platform for teaching and learning that can be used by every institution. Why we want to develop this? Because we want to monitor the progress of each student. This is one issue that has been raised in Indonesia. Because if we have some difficult student, we can detect which one, what are the problems, and how can we help him or her. That's the idea behind having the big data for education. So I think that's three that we have in this meeting. Thank you.
Good, thank you. Professor Shaila.
Okay. Though we have lots of limitation in Bangladesh, but our political commitment is that the digital Bangladesh within 2021.
By 2021?
Yeah, 2021 digital Bangladesh. This is our political commitment. And so in administration, in everywhere, digitalization is going on. But in medical education, actually, we are really very poor in ICT. So actually, we need some change. Though we are using OMR sheet in public examination, everything, but teaching learning, we are not using any. So today, teaching learning session, I have learned some things that I can implement. And I can suggest with Professor Azad, you know him very well, our DG, how can we improve our quality of education, medical education. And we have no infrastructure in medical education. Again, some media, the structural development, we need more. Otherwise, it is not possible. Only mobile phone cannot change the ICT. We need lots of things, logistics support, everything is needed.
Thank you. Dr. Delanta. Sri Lanka. We won't hold you to this, but I am going to be in Sri Lanka on Saturday at a medical education conference. So here's your chance to stir them up.
Okay. Regarding first one, as I mentioned earlier, the outsourcing should be minimal. That's the one. Outsourcing should be minimal. Yeah, because then we have to develop our own people within the system for the maintenance and those things. Otherwise, what they have mentioned here is that it is not standardized, it is ad hoc when the things are get outsourced. So that's the one key message I got from here. I don't know whether it's practical or not, but I think there is a point. According to what we are facing at Sri Lanka, because when we need the person, we can't get him down. But if you have a person within our system who is trained enough in ICT, we could have easily used him for our requirement. So if we can improve the capacity of our own people within the system, That's one key message I got from here. Then the open source software and the online learning, because it is really hard for us to get health professionals to the physically present at the training programs. That's the one key difficulty we are facing, to get them physically to one place for a training program. So if we can develop online training programs for continuous professional development, they can be trained at their own setting. So second message is that I don't know whether it's MOOCs or not, but anyway the Moodle platform or the Google platform, if we can use it, not very massive one, but if we can have certain training programs even in smaller scale, if we can send them to the health professionals and get their involvement for the training program. It's really difficult to be, because there are remote stations and there are one-man stations where people can't come for the center for the training programs you coordinate. So if you can have something online for them to be have a continuous professional development, so that is the second thing. And for the administration related things, to use sort of Google, like today we have learned about this Google Docs, Google Forms and various these things. If you can use them in related to administration, related to institutional administration, where people can send some feedback, so the student feedback, student complaints, or the whatever the thing, where the training schedule, exam schedules, if you can get them down as a from Google platform in relation to institutional administration. That's the third thing.
Can I ask you a question? Yeah. And we've already talked about it, so I'm being a little bit naughty, but we've got a chance here to get ideas from colleagues from other countries. We were talking about the challenge of introducing any form of interprofessional education in Sri Lanka. And we both agree it's a challenge. Yes. And it's a challenge for all sorts of reasons. But partly you were saying because of the very strong unions in Sri Lanka who get very threatened whenever there's any talk about any sort of shared training. Now, I just wondered, have people come across the same difficulties? Because Sri Lanka's you've got a commitment to introduce primary care teams. You're talking about family clusters. So moving a bit like Indonesia is. Everybody's talking about more team-based care. You're going to get stuck at the first fence if you don't start having a bit of thinking about how to unblock some of that. And I just wondered if other people had difficulties, had examples of overcoming the difficulties. Not everybody has difficulties with getting some interprofessional education going. I mean, you're the most recent example. Maybe Indonesia the next most recent, and Thailand's done it for quite a long time. So any sort of sneak hints of how to unblock this that might be useful for when Dr. Landra and I are talking on Saturday in Sri Lanka on this topic. How did you have a resistance to the interprofessional education agenda? How did you get it moving? Yeah.
Previously we had a
turned off.
We do have interprofessional education because in our teaching hospital they are training for the midwives and nurses, and lately we are accepting more students, medical students, and also the training program for the postgraduate students have expanded. Supposing in my University of Medicine too, the affiliated hospital, North Oklahoma General Hospital, we had a nurses training school over the fence. They have to come into our hospital and they have to have a clinical training in the wards, outpatient department, labor room. But the problem we are now facing is that because of our postgraduate students and the undergraduate students number are increasing, they didn't have chance for the practical purposes. So at the same time there's a nurses university which is in the center of Yangon, but these students also have to go to the affiliated hospital of the University of Medicine 1, and they have their clinical training there. We don't have a separate affiliated hospital for the nurses university. The interprofessional education and interprofessional relation which we want to build is that we want to make them a team-based teaching and team-based nursing, and we want them to become a team when they were posted outside after the university. So the main thing is that we want the better care for the people. Another thing, the second thing is that to reduce and solve the minor liability problems which can occur in the medical care day in medical care in our health services area, because teamwork like the shock drill and emergency or condition, mass disaster, mass accident, we can't do it alone. So we have to have a teamwork with these special nurses from the specialty subject like neuro, orthopedic nurses, theater trauma nurses, and also the anesthetist nurses. And also with the obs and gynae, we will need a nurses counselor which will be tracing the mothers, especially those who had a miscarriage and termination, back to their home and to bring them back for the proper counseling and management. That is what we are looking at.
This idea of getting together around a practical problem, like the emergency response, is a good one. Yeah.
I want to share with what happened. What I mentioned, 1982 or 1982. At that time, it is the initiation from Faculty of Medical, because they are the first faculty who has been established, and then they share the resources with Faculty of Public Health, because when they're going to have the medical student to go to the field, they need the skill of the public health. And the public health also need the skill from the medical faculty to provide like simple curative things. So it starts from sharing the resource, and then the faculty of public health, they initiate IPE, okay, IPE with these two. They start with these two faculty first. And then later, the other faculty in health science people, they found that it is very, very, very interesting, and it can contribute to better skill in community health for the health science people. So other faculties start to join. So I think it starts from sharing resources, both financial and both intellectual, lecturer, and some other things. So from the field practice, they evaluate that it saves the cost, and the student can learn more from each others, and it can create kind of the teamwork between the health science people. So that's why from this, more faculty include in this approach. And recently, I think faculty of veterinary also, they are not from health science, but they include in this IPE.
So starting just small.
Yes, small.
With a couple of faculties sharing something,
yeah,
sharing it
resource.
Can be useful.
Yeah.
So doing it under the radar. I mean, one of the things I thought was really interesting yesterday, I think it was Wanisha that said it, which is that, well, we may not know, we've had, it wasn't actually Wanisha, but she confirmed it, you've had IPE in Thailand for years, but it wasn't called that. But the notion of some form of collaboration, whatever fancy label you give it, and there's probably some going on. Anyway, we don't have answers, but I just thought it'd be interesting to because it's a problem for everyone.
To take home to implement something within 2 to 3 months. That's why I didn't mention.
Oh. Well, that's realistic. Yeah, no, fair enough. Okay. Dr. Tenzin, Mr. Tenzin.
Not doctor.
Never mind. What would you like? What are your sort of take-home ideas? Don't let me restrict you like I restricted Dr. Delanta.
Probably I'll be a little bit more generic in the sense. I think if you look at the last 3 days, I think we saw that how Thailand actually took opportunity or leverage ICT to empower health professional education, and compared to what we are at the moment, I think we have many things to learn from the last 3 days, because in Bhutan we are trying to embrace ICT in a big way, actually, big way. And the government is already using G Suite, Google Suite. So the entire government machinery, I mean, we are using the Google Suite. So, but insofar as the health education is concerned, perhaps as someone mentioned, I think we have to catch up with the other sectors. So, so probably there are many things that we can learn from this last 3 days, but also there are lessons to be learned. If I remember correctly, someone said that if we have a 21st century student, a 20th century teacher, and if we have just 19th century infrastructure, perhaps I think we will not. So perhaps when we take on board, I think these 3 things should be same sort of time frame, wavelength, so that we are on the equal footing. And we have 21st century student with 21st century teacher and I mean up-to-date sort of infrastructure. So I think this is one big lesson, that when you invest in infrastructure, of course ICT keeps on evolving, changing, but still then I think this is one investment that you have to keep in mind. I think this is one critical area that I thought we should take on board, because we are still learning at a learning and implementing phase. The other thing is superficial virtual learning vis-a-vis face-to-face learning. Where to strike the balance. So I think this is also a critical sort of thinking that we need to adopt. How far we can actually go on adopting ICT for our learning process. So this is one thing. The other thing, quickly, because I think we are actually, is we are in the process of developing the EPIS, Electronic Patient Information System, nationwide. There are few big hospitals who have done this EPIS, and but we are yet to find one country who has done nationwide this kind of electronic patient EPIS, so to speak. Currently, we are in the process of receiving EOI, expression of interest, from both national as well as international vendors. And fingers crossed, hopefully, because if this system is successful, then it will revolutionize our health system in a very big way, because this is both outpatient as well as inpatient. So it will cover the entire, before you ask the question. But it's, having said that, it's not that currently we are not using any ICT in our health systems. We do, but these are very standalone systems, apps, and our main concern is when we take on board this EPIS, the interoperability between all these various standalone apps and systems. So that's why we are at the beginning only trying to address all these issues. So we have a handful of things to do in the coming years, and perhaps from next year it will our 12th five-year plan will start, and so we will also have a new government in place next year. So we would like to take on board all this, and hopefully we will have the same political commitment that we currently have with the new government. Thank you.
Thank you very much. I mean, what really strikes me about your examples is how you have to think when you're investing in new hardware. There are so many other things to go with it. And for example, in Bhutan, at the moment, in the basic health units, like in many countries, frontline services, you have registers. When people consult, you have patient registers for maternal child health or immunization or whatever. You don't have patient-held records in ambulatory care. So you're trying to go in one leap from registers straight to electronic patient records. So the big question is going to be, in the hospitals, of course, you already have individual patient records. So the question is what you're going to have to do now to get the next generation of graduates, be they nurses, health assistants, or doctors, used to thinking about recording family-held, either individual or family, at the most family-held records, where you record individual consultations and how you store them. That's totally different from recording in a register for a particular clinic. And I know it's being discussed because I've been in country, but it's going to be a revolution, and it's not just the IT revolution. Okay, so that's the countries around the table. Now, Thailand, I wasn't going to ask you so much. Yes, well, I was going to come to you. Well, no, on Thailand, I suppose the question is, you could turn the question on its head. I mean, I can ask, and if you like, I will. What 2 or 3 new things, new ideas do you have from the meeting? But I'd also like to ask you, what have you learned? Because you've been the hosts for this conference, but we've had this is our third meeting. What have you learned from listening to other people's experience with the same issues?
Yes.
So who am I going to give
my
you?
take home. My take home. Right now, I'm in charge to look after the program Master of Public Health in my university. So what I'm going to take home is that I will introduce the ICT, the step that I introduced. So I need to motivate the lecturer who involved in the course phase, and then I'll provide with the training. Because the university have, I'm sure the university have the technical support team. So I'll consult the technical support team and then conduct the training for the lecturer. And I'll ask them at least one chapter, one selective chapter to do to use the ICT. So whatever chapter, but it depends on their choice. So the appropriate one. So this is the things that I'm thinking in my mind to do it. But for the country, I think Dr. Thinakorn can contribute something, I think.
My take-home message is my own. I think 2 things. The one thing is that as I work in the Ministry of Public Health, the most important thing is Ministry of Public Health Thailand and Ministry of Education should sit together and talk together and plan together. We try to bridge the gap between the demand and supply. I think this is the key issue. The second thing is not for country. I think for the region. IHPP Thailand, with the close collaboration with Professor Vanisha and with Dr. Nong from the Khon University, we conduct a 6-day study visit to strengthen transformative education in the region, not in Thailand, by using the best experience from Thailand. We learning and sharing between Thailand and our visitor. We work with Dr. Dilanta. He sent 2 groups of Sri Lankan teacher to us. For the 6-day workshop, 2 days for the lecture, and we have 3 days for the study visit to see the field how should Thailand work in many issues. And the last day we come to sit together and talking and deciding what is your take-home message. What would you like to do after you finish this study visit and come back to your countries? This is we try to strengthen the transformative education in the
No, it's
region.
very interesting. And on that, what kind of people did you send? You said 2 study visits, you said.
We have 18 paramedical training schools, allied health professional training schools, 12 people, 12 academic staff selected from those institutions, and 1 regional training center manager was sent to Thailand for this one.
And what's the sort of vision? What's the how does this fit into?
They were selected based on a project proposal, even in Sri Lanka. Yeah, they were selected based on their, some were selected, for example, physiotherapy, school of physiotherapy, the senior tutor selected community-based approach for physiotherapy. So he came here and he polished that proposal, and he has to go back and implement that project proposal within his school and among his trainees. Everyone came with a project proposal, and he has to polish this one in Thailand and modify it and refine it, and now they has to implement that within their training school. That's how they have selected based on the merit of the proposal.
Okay, so we're getting one more.
I think we try to not for the study visit. We try to have some training. We link with many universities in Thailand, for example, Konkan University with Dr. Nong to train in some master degree or for some short course training. So the aim, we try to strengthen transformative education and other fields of human resource for health in this region. This is our mission.
Okay, well, that's a very nice entry point into anything we want to do, more regionally, collectively, with or without WHO. This isn't a call for proposals to WHO. We're just the candidate. But are there things you think, as you go home, that you've got to know each other? There's an email list, the obvious thing. I'm sure everybody would be very willing to be emailed and contacted with questions in a very informal sort of email network. That's the simplest thing to do. Is there other there's Thailand's running a course, maybe others are evolving. We heard a little bit about Japan, what they do, but that's a long way northeast. Any other thoughts on what would be useful to do in terms of exchanging knowledge or experience? Just remind you that in April we'll be having a regional meeting on the decade of strengthening health workforce. There'll be a day on transformative education, and there'll be a day on retention, a day on strengthening governance and data, because this is part of WHO's cycle of tracking the decade. So there will be another opportunity there, and I've got ideas. If I'm going to talk about myself, I've got ideas from this meeting about how to structure that event so that it's useful and it builds on what you've all been telling me about what you're already introducing and what your questions are, and so we can have you can never have as much discussion as you like, but at least keep the discussion moving forward and not just go backwards all the time, and some continuity for that meeting would be very good. So we'll see what we can do about that. But other suggestions on some more collective follow-up from this discussion on this agenda of transformative education. There's this 20 Asia, what was it, was being mentioned. There's some network of professional education that's meeting in Hong Kong.
AMER.
AMER.
It's on 12 to 14
December. Is everybody, are people here who are educationalists members of that network? It seems to be the biggest one that I've heard of.
The biggest one actually in Singapore.
Singapore, okay.
In Singapore on January 2nd week. I think it will be bigger, and they have a special session about interprofessional education.
Okay, and that's again medical education or education in health professional education.
They're moving to health professional in general.
Yeah.
So we're moving away from just medical education.
Yeah. I must say I would very much support that move. I mean, to me, the litmus test as we're going forward is is what we're doing, whether we're investing in ICT or changing the way we train our health workers, is it going to help us make progress on universal health coverage in one way or another? Can you make a plausible link between how you propose to invest massively in whatever it is to do with ICT, patient records, and the ultimate goal of better access to care, better quality care? So there are lots of, my impression is, and you're far more knowledgeable than me, that there are a lot of networks already in existence on education, health professional education, be they CADA specific. Probably the Cinderella may be the allied health professionals. There's plenty for doctors, quite a lot for nurses and midwives, and maybe physios, I don't know, but less the people who are what I call the frontline health workers. And that's, I'm still interested in ideas. Maybe we'll try and have a discussion about what we could do for that group. It's different, I know, for all sorts of reasons that Tintin was talking to me about, but they mustn't get forgotten just because it's more difficult. And maybe it's more domestic, but one might still get ideas from other countries about how they are trying to change the way they look at their frontline health workers, which include everything up to a doctor increasingly, gradually, not everywhere, but gradually, at least at the district level. So let me just one last open moment of reflection on any other suggestions for collective action or events that are coming up. Yeah, go ahead, Daniel.
Well, thank you for the time. Well, actually, I want to emphasize what I have been talked about yesterday about developing the Asia-Pacific Interprofessional Collaboration Network. But one activities that I want to propose is how if we make a 2 or 3 years project about evidence summit on IPE and collaborative practice. Because I think like yesterday what Professor Watanabe presents, that the recommendation actually didn't have a very strong evidence. So I think this is one thing that we need to address, and I believe we cannot do it alone or just in one country because the implementation is very restricted or maybe in a very early stage. So if we can create a network and do this project, actually might be better and might be helpful for WHO, and maybe not just CRO, but we need to also involve the Western Pacific office.
Well, I was just thinking, you do have a body called the Asia Pacific Observatory on Health Policies and Systems Research, which is bi-regional. If there was I mean, it's not hugely rich, but it's interested in supporting research on innovative things, not just same old. How do you? Okay. So you know, get some ideas together, talk with your colleagues, and we could talk again about whether that would be one route. And there's the AAAH network, but again, that doesn't have lots of funding resources. But get your ideas. I think it's personally, what do other people think? I mean, it might be quite an interesting idea, but inter-country research can be a little testing, but there are ways of doing it, and the APO does work through research networks. Mm-hmm. So maybe that we could think of something. I mean, there's an issue around methodology, because I think you can't expect it to be done in a conventional research way, but I think it was you talking about 2 years down, that you'd done some attempt to capture what had changed 2 years down the line, not just after one week's course. And that's the kind of thing that would be interesting. And I certainly think a bit more systematic case studies, even if it's not really hardcore research, could be very useful to the agenda, to demystify the issue and to talk about how you've introduced it as much as looking at the effects and what difference it made. We can think of other ways. And I think that's quite a nice idea to run with. Leave you to run with it without involving me at this stage.
Maybe I want to ask the Thailand people from Thailand, how do you get the funding from JICA? Because we are on an early talk with JICA Indonesia, and they show quite some interest about it. But we need to follow up and maybe learn something from your experience on how to make this happen. And maybe to the other delegates, after we ask for your contacts, if you do not mind, then we send some something based on that list. Thank you.
Yeah, does anybody object to sharing their email? I did do one mass email to everybody before the meeting. So, yeah.
The directory, me, ma? Oh, no, cóเป็น organizer. I'm asking whether we have the directory that everybody have the email of.
We've got a list of everybody who was invited. I've got, and I sent an email to pretty much everybody. So you've all got everybody's emails already. You can't always tell who's who from an email address, but we could do that. You should have got it. Maybe you didn't because maybe your name came a bit later. But we can make sure that we, yeah. No, you're not on it, so we can add you. That's easy. But would everybody like that? Just of having a sort of email list. Okay. On JICA, I mean, with any donor, the secret is getting to know the people, to be honest. So starting country, we've had people here in this meeting. The JICA is very big on UHC, very big. And if you're talking about UHC, you're talking about access to medicines and health workers and all those things. I think if you can package it quite easily, how you get the money, how you actually tie down the money is always more complicated with any donor. But first of all, it's getting to know the individuals. And we're trying as WHO to do a lot with JICA. One of our new bosses is heading the cluster on universal health coverage in Geneva, in WHO. She's Japanese. So Japan is coming very strongly out into the UHC and knowledge agenda at the moment. So I think they might be open. Okay, that's a good idea. So a bit of collaborative knowledge sharing and production. What about you?
I think I like this kind of atmosphere. So after the seminar, and then we discuss what kind of things that each country take home. So I think it's quite constructive instead of just listening. And then but what we do is that we listening and then we digest it here, lead by our 24 hours. Dr. Viridas. So I think this atmosphere is very, very constructive. So if it's possible, every seminar, I think lead by the zero. The zero should do like that. So I think it's
to change in zero, yes.
Yeah. So everybody have some take home. Yeah. And the second point is that I think what you mentioned is very interesting, that you want to focus on the primary, the front line health workforce, because I think the movement in the past of the WHO, they make it vertically at each professional. Each strategy, when strategy come to professional, they digest it in different way. You know, they try to empower their own professional. So the way they digest it at the level of care is different. But when we talking about like the collective primary care health workforce, it includes many multi-stakeholders. Skill mix work there. Sometimes it's doctor, sometimes it's not doctor. Sometimes it's nurse, sometimes it's kind of community health workers. So there are variety of category working there. But the aim is that how to make the rural people or underserved people reach the health workers, whatever kind of health workers. So I think the WHO have moved about primary care, but I think primary health care, they targeted at the volunteer things, volunteer things. And when they're talking about the HRH strategies, it targets on the cadre, professional things. So I think it's the primary health care people, they are neglected. So I think it is a good strategy if zero thinking about moving this forward.
Well, we certainly are. The other thing you all probably know, if you've got 1 or 2 more minutes, is that we have a new boss in Geneva. Dr. Tedros is the new DG of WHO, and he's in the middle of developing, we're in the middle of our global program of work cycle. And we have a meeting next week to review the draft program of work in Zero, and then there's another big meeting in 2 weeks later in Geneva. And I know some people from Thailand are already going to that. I don't know if anybody else here is involved. But just to let you know, the 3 big strategic priorities One is universal health coverage, 1 billion more people having universal health coverage in the next 5 years, on the assumption that 4 billion roughly do. So 1 billion more, up 25%. And then there's another 1 billion people being kept safe to do with the emergency response, being more effective in its emergency response. And the third one is to do with equity and the SDGs, which, to be honest, is a bit similar to UHC, but I'm not meant to say that. but they're calling it the 3 billion targets, 1 billion, 1 billion, 1 billion. Now, in the UHC one, big emphasis, again, on primary care, frontline services, whatever language you prefer to use, and moving away from the WHO's siloed way of working. And I've been chairing a working group, an internal working group, on new ways of working in WHO to try and break down these, and it's same in ministries. I mean, WHO is a reflection of many ministries of health, isn't it? We all work in our little departments. So we're conscious of it, whether we'll be successful in changing. What I can certainly say is in our meetings, we will be talking about frontline services, primary level services, and not just about voluntary health workers, but about the mixed teams. And we're being pushed by our member states. I mean, countries in the region are moving fast already and changing their thinking about family practice, cluster-based teams. There's a lot already happening in the practically every country around this table. So I think we'll change with you, I hope. But thank you for that. Okay, guys, enough. I can see more iPads are coming out, iPhones are coming out, so I think we've done enough. We've got the balance between iPhones and eyes is changing. So if you're all ready, I would like to say a huge thank you to Thailand for organising it. Very well done. And for accompanying us also in these sessions. It's been very nice to have you there as well. Huge thank you to all of you for coming and contributing. So thank you very much. For our doughty rapporteurs, where are all the rapporteurs working hard? Hi, Basai. Thank you so much. And for people who provided us tea and cakes just after lunch. But anyway, thank you, and let's keep this going. Thank you very much. Have a nice day. Bye-bye.
Do you mind to have a group photo?
Yeah, sure. Yes, sure. Yeah, we don't mind at all. How could we have a meeting without a group photo?
The very important things.
Very quick.
Chasing flights.
What time are you flying tonight?